Assalamu alaikum. We are starting today's session. We have a female patient, Mrs. Lisa, 33 years, came with the complaint of difficulty breathing for 6 years. We will start after the time starts. Okay.
Did you adjust the timer? Where is the timer?
You can see it now. I share it.
Yes, I see. Okay. Hello, I am Dr. Zidan, one of the doctors in the clinic today. May I confirm that you are Mrs. Lisa, who is 33 years old?
Yes, I am, doctor.
Hello, Mrs. Lisa. As you know, we are here to have a discussion about issues related to your health condition. Is this okay for you?
Yes, sure.
So, can you share with me what's your complaint, please?
Well, doctor, actually, I am being really tired of this shortness of breath that I noticed it recently in the last weeks when I became unable to move upstairs inside the home.
Yes, you started to feel this breathlessness during homework, during staying even in your home place.
Yes, but it is with me since 6 months, but now it's untolerated, even inside home. Yeah.
So it's progressing. Did you notice that? Yes, and it's related to doing effort or exertion?
Yes, doctor.
Yes, it is associated with any chest pain?
No.
Associated with racing or pacing in your heart?
No.
Any dry cough?
No, doctor.
Any cough, even?
No cough.
Have you ever coughed up blood?
No.
Any noisy breathing?
No.
Do you wake up at night gasping for air?
No.
Okay. And did you notice that you increase the number of pillows at night?
No.
Any leg swellings?
No, doctor.
Anyone told you that you became paler than before?
No, doctor.
Okay, that's great. And apart from that, did you notice any change in your weight?
No, doctor.
Okay, any change in your appetite even?
No.
Any racing or pacing in your heart?
No.
Yes, I'm sorry. Any lumps or bumps anywhere in your body?
No.
Okay. Any joint pain?
No.
Any skin rash?
No.
Any high temperature or flu-like illness?
No.
Okay. Any problems in your vision, like any dryness in your eyes, any redness in your eyes?
No.
Mm-hmm. Any pain elsewhere in your body other than your? You mentioned no chest pain. Any pain elsewhere in your body?
No pain, doctor.
Okay. Okay. And apart from that, did you notice any change in your skin, that it changed in the color or any red spots?
No, doctor.
Any tightness in your skin?
No.
Okay. Any change in the color of your fingers, or exposure to cold, that it become red or blue?
No.
Okay. And apart from that, I will ask you some private question. It should be asked in all my patients. Okay.
Yes.
Do you have any recurrent miscarriages?
No, doctor.
Okay. Any chance that you are pregnant right now?
No.
Are you taking any birth control pills?
No.
Okay. And what about your cycle? Is it regular and normal in amount?
It is regular, yes.
So everything is okay regarding this. And you are not pregnant. Do you have any kids?
No, but I had 2 relationships.
So do you have any unprotected casual relationships? I'm sorry.
Yeah. Yes.
Okay. And when was your the last time?
Well, it's like very 1 year ago.
Yeah, and 1 year ago. Okay, and uh, do you have any piercing, tattooing,
No,
any blood transfusion,
no.
any past medical history I should be aware of?
No, doctor, but I feel tired also.
Yes. You feel fatigue or tired. Is it?
Yeah.
Can I ask you how many steps you can walk before you got this shortness of breath?
Oh, yeah. Well, well, it's like half of the stairs. Yeah.
And you mentioned that this condition is progressing by time.
Yeah.
Okay. And you mentioned no pallor, but there is fatigue or tiredness also with exertion.
Yes. Yes.
Okay. And what can increase your condition apart or exacerbate your condition apart from doing exertion?
Well,
Anything?
nothing else.
Okay, and anything can improve your condition apart from taking rest, like any
No,
medication?
no, doctor.
Okay, okay. And you mentioned no kids? Okay. And any hospital admissions, any surgeries?
No, doctor. No.
Are you taking any medications? Any
No. I'm fine. I
any
don't take
over
medication.
yes, any over counter um,
No,
painkillers or
no,
any medications? Okay. Do you
no,
have any allergy from any kind of medication or food or?
no allergies. No.
Okay. Do you have any family history of similar condition or any family history of note?
Yes, I have two brothers. They have emphysema.
Mhm.
Yeah,
Emphysema.
two brothers. Apart from that, nothing else significant.
Do you have any problems in your liver?
No.
Okay.
What do you mean by
And
liver? The work?
no, the
Oh, no, 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 no.
any liver problem. Okay. Any tummy pain, any tummy
Uh,
distension.
no, no, no,
Okay. Any change in your bowel habits, like any loose motions, any constipations,
no, no,
any change in your motor work, like any frothy urine, any change in the amount, color, frequency.
no, no,
Okay. Any headache.
no,
Okay. Any recent high temperature or flu-like illness?
no.
Okay. And you mentioned that there was. Do you have any travel history?
No, doctor.
Okay. And I'm sorry to ask you that, but I'm asking this to all my patients. Do you do any party drugs?
No, doctor.
Okay. And what do you do for a living, and how this affecting your life?
Well, I am unemployed at the moment. I was a cleric in the hospital.
I'm sorry. What do you mean by cleric?
I mean, secretary in the hospital ward.
Yeah. And why did you lose your job?
Yeah, because of this shortness breath.
I'm really sorry for that. Yeah. Okay. And can I examine you?
Yes, sure, doctor.
Yes. I will examine my patient generally. Is there is any characteristic features like any autoimmune features? Any, do you have any dizziness, especially from standing up from
No,
sitting?
no, doctor.
Okay. Okay. Any cachexia?
No, so you find a normal built, general built female, and she is lying comfortable, and there is maintaining on room air.
Yes.
And
I will check.
but-
Yes.
yeah,
I will check the vitals, especially the pulse. Is there any irregularity, any abnormality?
No, the pulse is 80 beat per minute, regular, and the saturation is 94 on room air, and the
Saturation
blood pressure is normal.
94. Is she doing effort to take breaths, or she's comfortable in taking breathing?
When she is lying, she's comfortable. Yeah.
Yeah. Okay. Okay. And I will check the hand if there is any characteristic clubbing, pulmonary edema, any wasting in her hands, anything.
Negative.
Okay. Okay. I will also check blood pressure. Is it normal?
Yes.
Okay, I will check the proximal myopathy by asking my patient to raise his arms. Don't let me
Yes. Negative.
lower it down. Okay, negative. I will check the eyes if there is any pallor or jaundice.
No, normal.
Okay, inside the mouth, is there is any mouth ulcers, any characteristic features like any candidiasis, any?
No.
Okay, I will check the neck for any lymph nodes.
Normal, negative.
Okay, and any raised JVP?
No, negative.
Okay, okay. I will listen to the chest or full examination of the chest, starting from chest movement. Is it normal?
Normal, yeah.
Percussion note.
Resonant, normal.
Resonant?
Yes, normal.
Normal. Okay, and auscultation, basis and the apex of the lung, and
Yeah, normal.
normal. Okay, and I will also listen to the heart quickly if there is any abnormal murmur.
No murmur.
Okay,
What
I will
else?
check the heart. I will palpate if there is any shifting of the apex of the heart.
What else?
Also, I will any parasternal heave. Any,
yes, excellent. B2 is palpable. Yeah, and loud.
Yeah, I got the case finally. but it's not like normal to find everything is negative like that. Okay, I will check the legs if there is any edema.
No edema.
Okay, okay. So Mrs. Lisa, can I ask you what's your concern?
Yes, doctor. What do I have?
Miss Lisa, we need to run some tests to be sure about your diagnosis. But from what I get from you, and after I examine you, I'm suspecting that you have a condition called pulmonary hypertension. Primary pulmonary hypertension. Don't bother yourself by the name. It means that there is increase in the pressure in one of the in the arteries that is in the blood vessels that is supplying the lung. Okay.
Yeah.
And this the cause for that is not well known, but we need to treat you urgently. So we need to admit you to the hospital and run some tests to confirm the diagnosis first, exclude others, and involve a group of specialists, including the chest doctor and the heart doctor as well. Do you have any other concern?
Will I be very bad later on?
I'm sorry to tell you that this condition is progressive, but we will start you treatment urgently to delay the progression of the case. Do you have any other concerns?
Is my relationships are related to that?
I don't think so, but we need to exclude it out by doing HIV test and also to exclude some lung infection related to this unprotected casual relationship. Do you have any other concern?
No, thank you, doctor.
Okay.
Okay, you want to ask more, Dr. Dina?
ask more. والله هو لخبطني
Occupational
لأن
and
I
social?
didn't get the case يعني
Social, yes. Social. Did you ask? You have still smoking alcohol?
No, very important. I'm sorry, I forgot to ask you. Do you smoke?
Oh, time.
لا
Okay, time is up.
هاخد
Time is up, please.
هاخد نص دقيقة زيادة ماليش دعوة. Do you smoke?
She smokes, yeah, and like 20 years and 10 cigarettes per day, 10 packs per year.
10 packs per year.
10 packs, yes.
Yes, yes. I need from you, Mrs. Lisa, to stop smoking, as smoking can worsen your condition, and I can help you, but by referring you to smoking cessation clinic. Do you have any? Do you drink alcohol?
No, doctor.
Okay. Okay. Thanks. I finished.
Okay, examiner time.
You did well. Okay. So what is your differential diagnosis?
So
First, what is your findings? Your findings.
My findings. Mrs. Lisa, young age, 33 years old, complaining from shortness of breath, fatigue, which is progressing on exertion. Okay. Apart from that, I didn't get any palpitations, any chest pain, or any leg swelling. And on examination, and she is a smoker. Okay. And on examination, I found that there is raised parasternal heave. Okay, and I should listen also to loud B2. My first differential will be primary pulmonary hypertension. Okay, and also she has unprotected casual relationship. I should exclude other chest infections related to HIV, like pneumocystis cerevisiae or all of this.
Yeah. You're very good. And what other differential diagnoses?
I can put also alpha 1 antitrypsin. She has family history of emphysema, but I didn't get any liver problems or any findings on chest examination. Also, I can exclude asthma in her age.
Oh, very good. Yeah. Regarding her diagnosis, what are the things that need to be investigated for?
Investigated for my golden investigation will be echo. Sorry, I will go for ECG, chest X-ray, and echocardiography, and confirm my diagnosis by doing catheterization, which will confirm by find the pulmonary artery above 25 millimeter of mercury. Okay, pulmonary blood pressure. Pulmonary pressure, I'm sorry. And apart from basic investigations, oxygen, also pulmonary function test and oxygen saturation should be done. And also I can exclude by doing troponin and for heart failure, what is called.
Okay, what is the different? What are the types of pulmonary hypertension?
Types of pulmonary hypertension. Okay, primary pulmonary hypertension, type 1, which is primary or associated with any connective tissue disorder. Okay, or any drugs like amphetamine. تقريبا كل ده within the first category اللي هو type 1. Okay, type 2 related to underlying chest problem. Type 3 related to underlying heart problem, heart condition. Type 4, I mixed, I think, I can't remember.
Type 4 is
chronic BE.
Yeah, chronic BE, chronic thromboembolic, yeah. And well, in type 1, there is the possibility of congenital heart defects.
Yes,
that's also possibility in this lady.
Or drugs, yes.
Yeah. Okay, and what do you know about the management plan in this lady?
management plan. After doing my workup to confirm the diagnosis and the golden diagnosis by heart catheterization, I will start by giving oxygen if there is any need for oxygen, and start dilators and vasodilators and diuretics. Vasodilators, Busentan, Eleuprost, calcium channel blocker, and phosphodiesterase 5 inhibitor, which is I forgot this. Yeah, this is the vasodilators for pulmonary hypertension, and
Sildenafil.
Sildenafil. Yes.
Yes.
And diuretic also, but I don't think she needs diuretic right now. And oxygen supply and other supportive treatments.
Okay, very good.
I should start by educate and counseling the patient about her condition, and the multidisciplinary team approach, including the cardiac and pulmonologist and cardiac doctor, pulmonologist, and physio, occupational and social therapist. And then I can go by admission of my patient and start her supportive treatment if she need any oxygen supply. Then the definitive treatment will be with this vasodilators, and or treatment of any underlying heart, مثلا congenital heart problem, any like that.
Yeah. Okay, very good, very good.
Okay, time is up. Yes, Dr. Abdullah, can you give her the comment? Then I will comment.
So, yeah, you covered very good things, and it's just because she's maintaining a room air, I think in management to start with the non-pharmacological in this case, and so also in the types, there is the type 2 is a left heart disease is the commonest, the one associated with left heart disease, and so we start pulmonary arterial hypertension type 1 is also associated with the congenital heart defects, with also associated with the HIV and connective tissue diseases. We have type 2 left heart disease. We have type 3 chronic chronic due to chronic lung disease due to lung fibrosis, or I'm not sure of the second. Type 4 is due to chronic thromboembolic pulmonary disease or other pulmonary obstructions. It's rare. And there is type 5, unclear and multifactorial mechanisms, such as sarcoidosis, one of them. Type 1 is the medical management, depends on the we have pulmonary artery hypertension drugs that you mentioned, and also if there is a response in the catheter to calcium channel blockers, and lung transplantation. Okay, the type 2 depends on the left heart disease treatment, and there is potential of pulmonary artery hypertension medications that may be acted here in trials. I'm not sure, I'm not updating myself. That's like I didn't read the most recent lines. This is 2 years ago. Also they are doing trials in the lung disease to see if there is benefit also, but there is surgical therapy in the type 4 chronic thromboembolic. And yeah, that's it. Dr. Basim, what can you add? Anybody?
Yeah. Okay, great, Dr. Dina. Thank you, Dr. Abdullah. You're done with the comment?
Yeah.
Yeah, okay. So let's start from the beginning. Then I will try to summarize about pulmonary hypertension. So we are talking about Mrs. Lisa, 33 years, with a short of breath for 6 months. Dr. Dina started the question by analysis of the complaint, onset, course, duration. It was good, but you didn't ask how it was started, either sudden or all of a sudden or gradual. But you asked for the duration, and he told you that it's worsening at the last weeks, but it was started earlier, 6 months back, and mainly with exertion. He gave you the case from this word. I remember today I practiced one day a case of pulmonary hypertension, and it was the same presentation, short breath with exertion. So it's a diagnostic and pathognomonic for pulmonary hypertension. Either, I mean, short of breath with exertion, either cardiac or pulmonary hypertension. Cardiac, I mean, ischemic heart disease. So from the start, you can be guided by this exertion, either pulmonary part, pulmonary hypertension, or cardiac part for ischemic heart disease. Okay, then you analyze the relevant system well about the cough, the noisy breathing, blood from the cough or with cough, any kind of cough, gasping or catching air while sleeping, how many pillows you are using, swelling of the legs. You did that great, but it was all negative. Then the central, cardiovascular system, it's also related a little bit. You ask for the chest pain and awareness, just to rule out any cardiopulmonary disease. Then you miss the genitourinary, and this is very important in such cases. I mean pulmonary. There is a lot of association between pulmonary and renal, pulmonary renal, like Strauss and connective tissue
Yes,
disease.
yes, I asked any fourth
You
urine
ask any
in your
really or blood in your you ask? Sorry if
yeah,
I
any change in
miss.
the amount, color, frequency.
Okay, okay.
Like two
So
questions
yeah, yeah.
yeah,
I'm
at the
sorry.
end. Yes,
So but that at the end, that's why I didn't catch it, because if you ask in the system review, I will write it. Maybe you
yes.
ask yeah, scattered before later. Okay. Then you ask for gastro GI. I mean tummy pain, any yellowish of the eye, and very important here the constitutional symptoms. You did it. The pallor, the weight, the appetite, fever, and lumps or bumps in temperature. You did. It's very important in such case to rule out serious infection and cancer. It's very important. Or connective tissue disease, SLE. It might come with this. Okay. Then you ask for the joint pain and skin, as skin changes, tightness. It's also perfect to rule out any connective tissue disease like systemic sclerosis, and it might be presented with pulmonary hypertension. Yeah, it's good question. The color finger also to rule out Raynaud and associated connective tissue disease. The CNS, you ask two questions, which is enough in this case, headache and eyes. Yeah, I guess it's enough. Eyes, you might have some change in the eye, like redness of the eye, scleritis, episcleritis in case of rheumatoid arthritis, or some changes in SLE if the patient is having SLE. And the last system you ask, it was also not related, but it's important to ask the female history. Female history in the form of miscarriage, pregnancy, birth control pills, the periods, and the kids. And she gave you the history of unprotected casual relationships, and you analyze it well when it was the last. And it was one of her concern. It's very important to ask this question when it was, if near or before the symptoms, even before long time, you can correlate by choosing the HIV. HIV can present for years, not only 1 year. So it can be present till years, I mean. Okay, family history, good. You ask for the family, he gives family history of emphysema, which is very important. You can put it in the differential as you did. 1 alpha antitrypsin, it's important to put here as a differential. Travel history, very important to rule out chronic or, sorry, atypical pneumonia or some related infection from travel, Legionella, but it will be little subacute than being chronic in such case. Medical history you ask for any long-lasting disease, any allergy, any surgery, any admission. Also, this is very important. HIV, you ask for recreational piercing, tattooing, very important in this patient to rule out HIV or to rule in. The most important thing, and you forget, and you should ask about in the exam, the smoking. You might put cancer in this patient, especially if there is constitutional symptoms. However, this patient wasn't having these things, so you might rule out cancer. But still, for chronic, you could ask or you should ask about smoking. What else related to smoking in this patient important? COPD. You can put COPD related to heavy smoker. Then the job, you ask for the job. We mentioned before the importance of job in chest patients, the occupational interstitial lung disease, like silicosis or asbestosis, and so on. It's very important. Or exposure to some dust or parrot or product of parrot or ABBA. Okay. Alcohol. Okay, we could ask also about alcohol. So let's go to the examination. You did examination great, starting by the general look, by the vital charts. It's very important, the vital charts. If patient is hypotensive or in sepsis, you can think about pneumonia. And you can also rule out fever, I mean PE, if the patient is having fever or tachycardia. So the vital in chest is very important. Then you ask for proximal velocity, eye, the mouth for ulcer, and for something else. I'm not sure what about in the mouth, but it's important. You ask it.
For
Neck
the
swelling for what?
candidiasis, I think.
Yes, excellent. Yeah, it was great question about candidiasis. You can just roll in HIV by finding candidiasis, and still you are thinking about BCB. It's great differential. The chest, you ask full examination of the chest, inspection, palpation, percussion, auscultation, and all steps very important here. Expansion in lymph node and percussion, hyper-resonant in emphysema. So every step is important. Let's take one by one. Inspection for scars, you might think about cancer and post-surgery in the scars. You can also, by inspection, check for the expansion, and it's important in expansion if there is some surgery before lobectomy. Then the palpation for the expansion of the lungs, both sides is very important as well for to rule out any fibrosis or any surgery, scarring of the lung. Then the percussion, hyperresonance, for example, for emphysema or asthma patient. This is the abnormality. I mean, auscultation is very important here. The wheezes, bronchi, or the crackles. Bronchi, you will think about asthma and COPD. And for the crackles, inspiratory one, not improved or not disappearing with cough. For interstitial lung disease or bronchiectasis, sorry, the interstitial lung disease, it will not disappear, yes. For the bronchiectasis, it will disappear by coughing out.
But I'm sorry, Dr. I
Yes,
think also chest tightness, was it asked, Dr. Dina, in the history?
yeah.
And the wheeze is important
About she did the expansion.
no, in the
I'm not
history.
sure. She asked for the noisy breathing. Yes, she asked noisy breathing. For asthma, you mean? Yes. Okay. So our differential, sorry, someone. Our differential. Sorry, Dr. Sausan? Hello?
Sorry, my mic is open. Sorry for that.
So, okay, no problem. I thought you were asking me. Okay. So the differential in this patient in the order. Yeah, sorry, I forget the most important finding in this examination, which is the loud P2. He asked you, he guide you to that. You should do it by yourself. Any cardiac examination starts inspection, palpation, and auscultation. No percussion here, but you should do these steps one by one in any chest or cardiac patient. So inspection, any scar, rule out scars for any mitral or valvular replacement. Then you detect the apex in place or not in place, downward, outward, any displacement, the character of the apex. Then this is by inspection. Palpation, you will, of course, if you count the apex, if you detect the apex, you will count in which space. And then the palpation for parasternal heave, for loud P2, thrill, sorry, by thrill in the pulmonary area or thrill in aortic area. It's very important. Then the auscultation, auscultate all the hard areas, mitral, tricuspid, pulmonary, and aortic. Then sit the patient down and check for aortic regurg in the sitting position with expiration. This is the steps of cardiac examination in quick review. Then you found that there is signs of pulmonary hypertension. It's very important in this patient. You got the diagnosis at the end, maybe at the last sentence of the examination. And it's very important. You might not reach to the differential or to the diagnosis of the case if you didn't do that. See, everything was normal. However, if for this long duration, I guess there will be core pulmonary signs. So the differential diagnosis, pulmonary hypertension, you can put all types of pulmonary hypertension. The idiopathic, the heart, the lung, and you can also put the HIV as a type. Okay. The other differential related to smoking, you can put COPD. You can put also asthma, as you did. Alpha-1 antitrypsin as a family history, but against that, no emphysema signs. You can say that. And COPD here is more wise than bronchial asthma, although the patient is young. But still, you can put COPD related to the chronic smoker. But both of them are accepted. So pulmonary hypertension and either idiopathic or the heart. You can't put the heart here because the heart examination was okay. You can put HIV as a cause of pulmonary hypertension, then the COPD and bronchial asthma, and last one alpha antitrypsin, and you can mention against that no emphysema in the examination. Okay, so any question, any comment? Let's read the comment. Is the
Hello,
is the
hello,
diagnosis
doctor.
Yes, hello, sure.
Hello, doctor. How are you? Thank
Fine,
you.
alhamdulillah.
Thank you. I just to ask, as I think the candidate, she asked about leg swelling, and the surrogate said there is no leg swelling.
Yeah.
Yes, I think in pulmonary hypertension,
Yeah,
should
I
the
agree.
patient have leg swelling, or maybe might be without leg swelling? This is
Yeah.
a number one question. Actually, I have many points regarding social history in this scenario. Like travel history, it is important, and actually, I didn't catch the candidate asking or not about travel history. special. Oh, very good. And regarding the pets in house, this very important regarding asthma or APA. And the very important, actually, in the Arab board last examination, the scenario was like this, actually, but there is something else. Like the husband of this woman, he work in a factory. He work in heavy metal factory, such as warehouse of factory, and she daily she clean his clothes that contaminated with some heavy metals. If you understand me. So the most important thing in this scenario, when the shortness of breath is vague, actually digging the history in social, like travel, pets in house, parrot in house, a new house, the job of the husband, the environmental of the house. Maybe there is a factory near the house. Maybe there is some dust near the house. This regarding social history. Actually,
before you go on,
yes,
can I comment on this point? You are totally
yes,
right. If I found any dry cough, because dry cough will guide us to asthma or fibrosis or interstitial
yes,
lung disease. Both of them very
yes,
important. Occupational asthma or any interstitial lung disease due to some job, like you said, working in a
yes,
special
yes,
factory and all of these
yes,
materials
yes,
that can
yes.
cause interstitial lung disease. So I didn't find any dry cough, so I didn't dig out through these details. Did you get my point?
Yes,
But it's a very
yes,
important,
yes.
of course, if I found in dry cough, of course.
Okay. يعني there is no يعني always there is a typical scenario. Like in this case, there is no leg swelling, but the diagnosis was a pulmonary hypertension. What I want to say that digging the social history in the shortness of breath cases, I think in most of cases there is a hidden agenda in this scenario, like shortness of breath, because shortness of breath has wide differential diagnosis, and usually the diagnosis in the MRCP basis or even in the Arab board case basis, there is something hidden in the diagnosis. There is no usually there is no pneumonia, like, or MI or angina. I think 90% to 80% of these cases, there is a hidden agenda. Like her husband work in their factory and she maybe have asbestosis because of her husband. That is number one. And number two, yes, asbestosis, yes. There is MRCB case in MCQ like this. Uh, uh, there is also, I have a final points regarding the metabolic causes of the shortness of breath, like uremia, anemia. I heard you explore anemia perfectly, like pallor, orifice bleeding. I think you asked about orifice bleeding from another orifice. Menorrhagia, I didn't hear you asking about menorrhagia, but it's okay. There is no baldness, there is no dizziness. I heard you. It's okay. Exclude asthma. I saw anemia. But there is another metabolic causes of dyspnea, like uremia. You should ask about pruritus. You should ask about hypertension, about anorexia, about earthy color, especially in the older age than this 33 years old. And number three, the psychological history is very important in cases of asthma. In meanwhile, I think the diagnosis of this case, when I hear there is no leg swelling, actually I exclude pulmonary hypertension. And I heard from the surrogate that he has fired from his job. I think I thought that the diagnosis was psychogenic. So please explore the psychiatric history very clearly in the asthma, and the shortness of breath cases, like what's about your mood? What is your mood? Do you have any previous stressful situation and so on. And I am sorry for this long.
No problem. Thank you, Dr.
Thank,
Muhammad.
thank
Dr. Muhammad. Hello.
What? Are you with me?
You're Dr. Muhammad? What's your name?
No, I am Dr. Hassanin. I am Dr.
Dr. Hassan,
Sorry.
because your name in iPad, so please.
Yes.
Yeah.
Thank you.
Okay.
I'm
Thank
sorry.
you, Dr. Hassan. Thank you for your comment.
I'm
Yeah,
sorry.
I agree with you. It's okay. I agree with you in some points, but I agree also with Dr. Dina. If there was any chest problem, I can't put any differential, but totally free of cough, totally free of crackles in the examination, totally free of noisy breathing. So I can rule out most of the respiratory system disease.
Yes.
Although
I
I
agree.
can put it,
I agree.
but
Yes.
it's not in this case. If there is some cough or any noisy breathing, I will directly put any occupational disease like silicosis, asbestosis, as you mentioned, according to the
Yes.
exposure. And I will
Yes.
go through this social at that time. But as long as no any chest symptoms or respiratory symptoms, I can rule it out and I will not ask for more questions. If I will ask all these questions, I will not do other system review, and it's not relevant in this patient to ask about the exposure while I don't have any finding in the history for the respiratory or any finding in the examination. If there is crackles, I will think also about. So it was
Sorry.
only for.
Sorry,
Yes.
doctor. I mean, in the history section. I mean, in the history section
Session.
about this question. Yes. Not in the examination or in the a differential diagnosis. What I mentioned regarding the history, the collecting of the history, not the clinical judgment of the case. Maybe there is in the checklist there is some question related to this. Thank you.
I agree with you. Maybe there is also some cases like that.
Yes.
But it will not be like this case presentation.
Doctor, can I ask you, are you Iraqi?
Yeah, no. Yes, I am Iraqi.
Yes. So I can identify your accent. Okay.
Yes, thank you.
Okay. First, brainstorming, يعني all the differentials were very good from you. I will go for any positive data for further analysis. Other than that, I will not have time for asking all of these if there is any no positive data to go through all of this. Did you get my point?
Yes.
So you are very nice differentials and brainstorming. We are thinking together, very nice, okay? But applicable to be applicable on the cases, any positive data you can go through. That's it.
Yes, thank you.
Yeah, thank you, Dr. Hassanin. Thanks, Dr. Dina. Any question, or I will just give a clue about the pulmonary hypertension? Yes, sure.
Yes, Dr. Basim, can I add something? If there is in the scenario discover that this is pulmonary hypertension, we should dig in the causes of pulmonary hypertension because they will ask us. It is important in the past medical history to ask the patient about clot history in herself or her family history of clot, because
very important.
And also in the medication history to recreational drugs, I think she's asked, and also did you use any medication for suppressing your appetite called furamine or any, I'm not sure about the name, but one of the medications.
Amphetamine, yes.
Amphetamine, it is a recreational drug. I think that one from.
We are using this amphetamine in USA for فعلا يعني weight loss.
Okay.
Okay. Right.
Maybe the patient even he's not knows the name of the drug, but suppressed appetite, because it is very important to be focused in the examination of pulmonary hypertension. GBB is the must.
Is the must. Yes.
And FiO2 in vital is the must. And because this is determined how to interfere with your patient, clinical judgment about admission, O2 saturation, how to give oxygen and diuretics. If the patient has no lower limbs edema, even in the history, you should examine and to be focused in the lower limbs edema. left breastinal heave and palpable second heart sound. This is mandatory for examination for pulmonary hypertension. I think this is, you did a very nice history and examination, but if you said to the examiner from the first, this is exertional, chronic exertional dyspnea for differential, I put pulmonary hypertension in the top because I found that is palpable second heart sound. Then the list, COPD, as Dr. Basim mentioned, asthma is a very far because comes in attacks. This is chronic exertional dyspnea for differential. Pulmonary hypertension, one of the differential. Then COPD, pulmonary fibrosis, and the rest. You exclude anemia, which is very important.
Actually, asthma, okay, it is not the top of the differential, but we can put it in the fourth or fifth differential. Maybe exercise-induced asthma.
He asked about this is progressive.
Noisy.
Progressive
Yes,
shortness of
breathing,
breath.
no noise.
The patient is not completely
Yes.
free between the attacks. Progressive.
Actually, I was going with the differential of pneumocystis cerevisiae because she has desaturation on exertion until I found this left parasternal heave, and I was listening to the heart. He should also tell me there is loud B2 as well on auscultation, and there may be raised GFB and leg swelling also in advanced pulmonary hypertension cases, but very nice to ask. I asked it in general about past medical history, but I should ask about any clot in the family, any family history of clots, any heart problem in specific, to exclude any congenital heart disease leading for this problem. And yes, thank you.
Yes, you did it well. You did
Yes,
it
I
well.
can
Okay,
also
thank-
examine the legs for any swelling, any pain, for the any clots. Yeah. Yes.
Yes. Thanks all. Dr. Dina, just and I have comments on the management plan. Investigation you can add also bedside test blood gas EDG
Yes, and HIV,
Yeah.
and screening.
screening for HIV. Yes, just help please. Just someone can read this until I will wait. I have just donate. Sorry.
भारी घेतला या हा देतो जायचे व्यक्ती ما اعترضت ولا مجاني مدير المناطق
Yes, no worries. I wrote your case, Dr. Abdullah, on the chat box. Okay.
Yes.
Okay, sorry, I was explaining this picture while I'm mute. Sorry. I will read it again. So pulmonary type 1, group 1, idiopathic pulmonary hypertension, hereditary pulmonary hypertension, drug-induced, and connective tissue disease, congenital heart disease, group 2, left heart disease, with hypertension or diabetes. Okay. And group 3 for lung disease, hypoxia. Group 4 for chronic thromboembolic embolism, and group 5 for miscellaneous. You can add, yeah, any sarcoidosis.
Yes.
HIV also can be added here. Dr. Dina, Dr. Abdullah, take 2 minutes or 3 minutes, then prepare yourself. Okay.
Yes, I wrote the case. You can say Mrs. Lisa, 33 years old, with leg pain. Okay.
Yeah.
Dr. Dina, before mentioning the treatment of pulmonary hypertension, the types, you can add, we can do first vasodilator test, either by using the calcium channel or nitric oxide.
I think she
According to the
mentioned
written, no, she said the lines of management all, but she didn't mention the vasodilator test. I guess
Okay.
so. Anyway, it's just for the teaching. I'm reminding all. This is the steps of starting the lines of pharmacological management of pulmonary hypertension. Don't forget to mention stop smoking and the social patient education counseling about the disease. It's very important before going to the pharmacological or and the multidisciplinary approach. We should mention also. Very important in this patient. Okay.
Yeah.
Are you ready, Dr. Abdullah?
Yes.
So this is the case.
Yes,
It's
the timer,
female.
please.
Let's assume the same. Patient name, Mrs. Lisa,
Yeah.
33 years with leg pain. I will start timer, then you can start after that. So Mrs. Lisa, okay? The same our
Sure.
patient.
Yes, sure. Yeah. Hello there.
Hello.
My name is Mustafa. I am one of the medical senior house officers here. May I confirm this is Miss Lisa and you're 33 years old?
Yes, hello, doctor. I am Mrs. Lisa.
Nice to meet you, Miss Lisa. Actually, we are here to discuss, I will take history and I will examine you about your leg. Is it okay?
Yes, of course.
May I know what happened? Can you tell me more?
Yes, I started to feel this leg pain and it's increasing by time. So it started 2 to 3 months ago.
Okay. And where exactly? Is it on the right or left leg?
In both my legs, doctor.
Okay. And is this, so you said started 2 to 3 months ago, and is it like kind of continuous all the time since then, or is it intermittent?
It come and goes.
Comes and goes. And for like since it started 2 months ago and now, is it getting worse in general?
Yes,
Or
yes.
okay. And where exactly in the leg is that?
In all my legs, doctor.
Okay. So it started in both of them together or in one and then went to the other?
Yes, both of them together.
Okay. Is it reaching to the knee or below the knee?
In all my legs.
In whole legs. And is there swelling?
Swelling. No.
Can I see it?
Yes. Normal legs without any wasting, any deformities. No. No scars.
Okay. Do you have pain in the moment so that I give you something for that?
No, I am okay, doctor.
Okay, so this pain you told me, is it worse when what worsen it? What do you notice that it worsened?
I mean, these common tags, I didn't notice anything, any specific can worsen my condition.
So no exertion doesn't affect that when you walk on it?
No, it's not related to exertion.
Okay, and when you try to elevate it from position, like, is it getting improved?
No.
Okay, is it worse in the night or in the morning?
Not related to a specific time.
Okay. So is it in the end of the feet or in the just in the whole the leg up?
Yes, it started at the my legs distally in the below the knees, then it goes upward to involve the whole my legs. Both
Okay,
my
and when it started, you said in the leg, and then went up distally, more like. For how long did that reach to involve the whole leg? That
yes,
progress.
Yeah, lastly the last 3 weeks, I think.
Okay, and then anything that before these 3 weeks happened, any flu or upset back passage, any infection you got before that?
No.
Okay. Did you eat something weird?
I can't remember a thing like that.
Okay, and then did you have any feeling of weakness? Yeah.
No. Yes, I have some weakness, doctor. Yes.
Okay, and where exactly the weakness?
Also in both my legs. Yes.
Okay, so are you able to manage on what? So this must be affecting you pretty much.
Yes, doctor. I even started to take so many sick leaves. I'm working as a teacher, and now I'm not able to go my work.
Okay, what is your baseline ability? Are you able to at the now at the moment? Are you able to walk on your foot, like just the gait changing, or you are unable to walk?
Yes, I feel that I am walking on a cotton wool.
Okay, and is there any loss of balance?
Yes, sometimes, especially when I'm closing my eyes. I'm helping you right now, okay?
Okay. Did you have any? So I want to ask you: Did you have any episode of facial droop?
Facial drop and facial what? I'm sorry.
Your face. Did it get drooping?
No.
Okay. Did you feel any weakness or tingling in your hands?
Yes, I started to feel this tingling. You didn't ask about the character of the pain, so I would tell you it's burning, tingling, numbing sensation, and also it started to involve my hands as well.
Okay, so when did it start to improve your hands?
Recently, last week.
Okay, and did you have any kind of difficulty in swallowing?
No.
Any difficulty in speaking?
No.
Okay, do you have any headache?
No.
Blurring of vision?
No.
Okay, and did you feel, I want to ask you, do you feel any kind of loss of your control on your back passage or urine?
No.
Okay, so did you have any past history of similar condition?
No, this is my first time, doctor.
Okay. And did you have any past history of high blood pressure,
No,
high blood sugar?
no,
Okay. And any past history of admissions at all?
no,
Any past history of you got any antibiotics recently or before?
no,
Okay. Did you have any past history of surgeries?
no,
Okay. Any family history of same condition of problem in the pain and legs or
no,
weakness? Okay. Any family history of nerve problems? For example, multiple sclerosis.
no,
Okay. So I want to ask you, do you smoke?
no,
And did you drink alcohol?
yes, yes, I'm drinking alcohol.
How much and for how long?
Some nights 1 cups and some nights 2 cups per day.
Like in the week, only 2 cups?
No, in the per night.
Okay. And did you have any allergy to any drug?
No,
And did you take any regular medications?
no,
Okay. And did you have any long-term relationship?
yes, I'm married.
Okay. And are you by any chance pregnant?
No, I don't think so.
Okay. How's your period? I'm sorry for that question.
Yeah, I have irregular periods, doctor. So I think it started to come every 3 to 6 months. I think it's very irregular.
And is it like light or heavy?
A normal amount.
Mm. And do you take any oral contraceptive pills?
No,
Okay, and so you have very good. So did you have any bounding feeling of your heartbeat?
no,
Any chest pains?
no,
Okay, any shortness of breath?
no,
Any? I want to ask you, did you have any problem in like dryness in the dryness in your eye or mouth?
no,
Any joint pains?
no.
Any tiredness in your body?
Tiredness. Yes,
You can't feel like
yeah,
you can't.
yeah.
Yeah.
Lastly, doctor, I feel so tired and I'm started to lose weight as well.
Is it more in the night or in the whole the day?
This tiredness not related to any specific time of the day.
Okay, and any night sweating,
No,
lumps or bumps?
no.
Okay, so how much kilos did you lose and for how long?
Yeah, for the last 6 months, I lost for around like 7 kilos, something like that.
Okay, and can I ask you, do you feel this weakness in the legs? Is it more floppy or like more like stiff?
No, it's not a stiff, doctor.
Okay.
I don't know what the meaning of floppy, but
Oh, I'm sorry. Yeah.
stiff.
So I want to ask, do you drive?
Yes.
Well, at the moment, until we sort out the reason, I would not advise, we would recommend that you stop driving.
Okay.
Okay. And we will help you with that later on. I want to start examination, and so is she on bed or sitting? And I will start by asking to walk.
Yes, there is a high stage gate.
Mm-hmm.
Mhm.
And are you able to? Can you stand beside the bed and then let me check? Can you close your eyes and I will support her?
Yes,
From
but
beside?
Romberg test is positive.
Okay. And I want to ask you. So can you, when she opened her eyes, she's fine, right?
Open what?
When she opening her eyes, she's fine.
Yes, she's fine.
Okay, and okay, can you sit down, please? Yeah, I want, or lie down. Yeah, thank you. I would like to check the blood pressure lying and standing.
Yes, there is a difference.
Okay, and I want to examine the lower limb, tone, by inspection, any atrophy, any deformity,
No atrophy, no deformity.
and
By
tone,
hypotonia. Okay.
and power. Can you put
Uh,
it up and then
power,
bend it,
there is
and then
weakness, but yes, there is weakness. Okay.
weakness all over.
Yes, you can't like identify which is weaker, the flexors or extensors.
Okay, and but she can stand up.
Yes.
Okay, and then I will check the I will clonus, any clonus,
No.
plantar response, bilateral. I'm sorry, this is tickling a little bit.
Extensor, upgoing
Okay.
plantar. Yeah.
Yeah, yeah, I will check the reflexes.
Hyporeflexia.
Okay, and I want to check the okay, and then I should check the cerebellar. Is there any knee to chin? Is she able to move the heel to chin, and then?
Yes, heel to chin coordination negative, normal.
And sensation?
Sensations, there is sensory loss for the superficial sensations, pinprick and light touch up to the knees.
Proprioception?
Yes.
Proprioception?
Start with vibration, because the vibration will lead you to the level. Okay. There is vibration loss above the anterior superior iliac spine. Yani high.
Above?
Yeah, above.
Okay. Until when? So I should go to the sternum.
Yes, as you like, above the anterior superior iliac spine, that's enough. To the clavicle, as
Okay, but okay, and then the upper limbs, is that weak? And like grab quickly, and the flexion?
Is that grip?
Yeah, and the upper elbow flexion and quickly the movement, is it weak? The power.
The power of the hands. Okay.
Yeah.
Yeah. Yeah. There is also the power is. You can say there is weakness.
May I ask you, what is your concern?
Yeah. What do I have, doctor? And is it curable? Yeah.
Yeah, we need to run tests and scans, and we're not okay.
No, continue.
So, Miss Lisa, actually, this is we are concerned because I need to look to the back, actually.
Okay, normal, nothing in the back.
Okay, and actually, we are concerned about this progression of events. We suspect something affecting the cables and in the that's supplying your movement in the legs, and feelings that's leading to you feeling the pain. And we need to run more tests for that, and that requires you to be admitted.
Yes. Okay. Thank you, doctor. Is it
Okay.
curable?
Well, it depends on the cause.
Yes.
But there are cases curable and there are cases not.
Okay.
Okay, time is up. Yeah. Can you start examiner time?
Okay.
Yes, present your case and go ahead.
Yes, present your case, then what's your differentials, and then the plan of management, including the workup and the treatment. Okay.
Sure. So this Miss Lisa is 33 years old, female. So my patient is complaining of chronic history of sensory and motor manifestations that is manifested by both lower and upper limbs involvement of the affection of the sensations and the motor functions without affection of the components of the neurological system without affection of the sphincters. In the form of, on examination, upper motor neuron lesion bilaterally, and I think there is no sensory level. The sensation is affected until the L3, L4. My differential diagnosis in this case depends on the duration of onset. So in this case, it's 2 to 3 months. It's getting progressive. I think here we need to check, especially in this age. So I will. There is no family history, so I think in this case, I would think of. I would think of. I would think of chronic inflammatory. Well, I would think of hereditary. I'm not sure of the diagnosis. I need to explore more on the upper limbs. I think one of the differentials is a chronic inflammatory demyelinating polyneuropathy, and also because it's chronicity, and also multiple sclerosis as first episode, but most likely, or other hereditary, motor neuron disease.
Yes.
Motor neuron disease would affect also, but in a typical picture. I should include also coda equina and conus medullaris in my coda equina in my differential diagnosis, but less likely because of the absence of radicular pain. Yeah.
Yes. Okay. I will discuss all of this. First, multiple sclerosis. Well, you will not find lower
later, Dr. Dina, later.
What?
Dr. Dina, yeah, let him do investigation and management, then comment in the differential.
Because he is very guided wrong. So the further discussion will not be beneficial regarding the case. So I will not go through more. Okay. I'm only explaining why his differential is not good. It's not right. CIDP, more motor symptoms. Okay, not sensory. This is sensory symptom mainly. But there is motor symptoms. Regarding the MS, purely upper motor neuron lesion, not involving lower motor neuron lesion signs. Okay, and this is my comments. Anyone can add more differentials or discuss?
In this case, vascular is less likely because of the
very nice. Yeah, it was very nice from you if you examined the anterior tibial pulse, if it's present, to exclude any peripheral vascular disease. Very nice differential, but you already excluded in the history, and for examination, it was very nice from you if you checked the peripheral pulses or the distal. Dorsalis pedis and anterior tibialis artery. Okay. Give me just 1 minute, and I will discuss the whole case now. Okay, I will discuss every single 1 minute.
Dr. Abdullah, there was something related to the food in the history. You remember, or I'm mistaken? Any food or meal she mentioned, or you are not sure?
I asked. Well, what is the question? Sorry.
Yeah, food. Did she eat something like that?
No, negative. Okay. She doesn't remember, she said.
Okay. Can you do your investigation even in general, then management, then until she arrives?
Yeah. So this lady requires she needs normal basic investigations plus, and then CT and MRI of the plus or minus MRI of the brain and spinal cord, and also requiring nerve conduction studies and EMG. Because of the trick, if there's demyelination disorder.
Okay, what else in the investigation? You want to do vitamins, for example? What do you think?
Vital what?
Vitamins, vitamin level.
Yes, actually, yes. I was thinking
Yeah.
about, but this is the upper motor confused me.
No, it's not upper, by the way. It's lower because
no,
hyporeflexia, hypo.
upper. She said bilateral, and it's
No,
like
she
a
said
face patient.
she said
I understood.
hyporeflexia. What I remember, hyporeflexia, hypotonia.
Hypo, as I understood, as a shock face. The patient is in shock face. That's what hyporeflexia.
Yes.
Not
Can we discuss the case now, or you will continue with the?
okay.
Yeah, he
Sure.
was going through the investigation, Dr. Dina, and the management in general. Even he didn't reach diagnosis, he should think about investigation and management.
Yes. Okay. Let's hear.
So go ahead,
So,
Dr. Abdullah. Yeah, what else in investigation
So
and management?
we need to check actually yes, I mean lumbar puncture also CSF studies. One of the things required if there is no contraindications. Looking if immunoglobulins and looking if there's any dissociations, cellular dissociations. The management depends on the investigation depends on the findings first. So if there is if the case is suggestive of vascular etiology, then I will go forward with the angiography and cardiac scans, and could be because of the anterior spinal artery occlusion should be with the sudden onset and rapid progression, not like this. In coda equina and conus medullaris, it may need a surgical review and also further scans. Also, we need in the manage the question.
What do you think about screening for tumors or paraneoplastic?
Yeah. We need to.
Mention them. Yes.
Well,
because of loss of weight, significant loss of weight, vasculitis. Also, you can think about. Think about even you didn't reach. Give some clues that it might die due to the diagnosis, even in the investigation and workup. Okay. So, are you done?
I don't know why the patient has weight loss.
Okay.
Actually, I'm not sure.
Yeah. So tell the management quickly. Management plan. How you manage quickly?
We need a multidisciplinary team approach. Getting the neurology and internal medicine and physiotherapy and occupational therapy, and also plus we may need to involve the social worker, and also then we may involve the specialized tests. We will start try things that may improve on the management trials of if we suspect demyelinating disorder. If we suspect, I mean, we may give vitamin E. If there is well, according, and then if I'm suspecting also a subacute combined degeneration, I may give vitamin B12 course of management. Yeah, and I don't think I would add else. If there is any anti-nuclear antibody, I will in the management. I will send screening if HIV related, and if there is any spinal hereditary spinal hereditary spinal pathology, or HIV, or viral etiology related. Yeah.
Okay. So let's hear Dr. Dina comment, then I will
Okay.
comment.
Yes.
Well
sure.
done, Dr. Abdullah. Thank you so much.
Thank
So Dr.
Yeah,
Dina,
thank you.
give us the comment. Thank you.
Yes. First, يعني إيه طبعا you have the whole information Dr. Abdullah, you are very informative ما شاء الله تبارك الله, but يعني بس you need to be more organized, okay? How to be organized by knowing that there is basics like analysis of the pain. Analysis of the pain started from the character. Anything can increase the condition, any relieving factors, any specific time related to this pain, and also where is the pain exactly, and the character, and something also nature, character and nature, and I think I forgot some of the analysis.
Feeling, improving,
I mentioned
Radiation.
radiation.
And
Yes, radiation. Okay. The full analysis, يعني what is the character of the pain? From the first or second sentence, I will give you the clue that is it's burning or tingling numbness sensation. Okay, so you will be guided. That is peripheral neuropathy. This is a pain diagnosis, peripheral neuropathy.
But doctor, you said I heard the plantar are extensors, right?
This is mixed upper and lower motor neuron lesion.
Yes.
Hypotonia, hyporeflexia with plantar extensor plantars or plantar upgoing. This is mixed upper and lower motor neuron lesion. Okay, the ankle reflex will be absent, and if you go through the knee reflex, you will find it jerky or hyperreflexia. Okay, so this is mixed. Okay, let's go step by step. Okay, the character will guide you to the peripheral neuropathy. Okay, then you should exclude the other. Anything can increase your condition, like any movement in the back of your legs whilst movement. You exclude claudication or any peripheral vascular disease. This is the second differential, should be excluded. And also, is it related to, as you mentioned, I think you asked this question, is it related to specific time of the day, like more at night? Do you feel restless leg syndrome more at night? And I denied this. This is the second differential. The third differential is radiculopathy. So the four differentials for leg pain are peripheral neuropathy, which is our case today. The peripheral vascular disease you should exclude by the analysis. The restless leg syndrome, by the analysis you can exclude it, and radiculopathy, any back pain, as you mentioned, no back pain. Okay,
nice.
Any trauma or back pain. Okay, so this is peripheral neuropathy. You can go through the what we can say, the differentials for peripheral neuropathy. What are the differentials for peripheral neuropathy? Can you
diabetes, most common, and we can have other metabolic conditions like hypothyroidism, amyloidosis, and then we have demyelinating disorders.
Can I write on in the page? Can I write? Is there any pen for me? Okay. The differential
I don't
for
know if you can how to do it.
Yes.
You mean in the share, right?
I think you can up the arrow. Pick up the arrow, the left one.
Severity, scoring and severity. Yes, what is the severity of the pain exactly? I can't find. Okay, so leg pain, differentials for leg pain are peripheral vascular disease, peripheral neuropathy, and restless leg syndrome, and radiculopathy. Okay, for the differentials of peripheral neuropathy itself, it will be diabetes, uremia, alcoholism, and I gave you alcoholic history. Okay, positive. Drugs like any antibiotics, any chemotherapy like vincristine, vinblastine, metronidazole, any nitrofurantoin. Also, vasculitis and autoimmune conditions, very important. Vitamin B12 deficiency, okay, very important. And also the amyloidosis, hypothyroidism, HIV, leprosy, I think multiple myeloma, paraneoplastic disease is the full differentials. Yeah. So I can repeat the differentials: diabetes, uremia, alcoholism, which is positive in this case, drug history, antibiotics like metronidazole, nitrofurantoin, chemotherapy like vincristine, vinblastine, then autoimmune and vasculitis, vitamin B12 deficiency, very, very important, okay? Vitamin B12 deficiency, which can lead to subacute combined degeneration of the spinal cord, which is our case today. يعني I mixed the case. This is يعني the case is pernicious anemia and autoimmune associated with Addison. Okay, I mentioned that there is dizziness and also may be associated with premature ovarian failure. I gave you the period is started to cut off. Okay, so this is autoimmune, and also you can put alcoholism. You should يعني give the patient advice about يعني stopping alcohol. Okay, because it's aggravate her condition. Okay. How we can analyze the case and exclude all of these differentials. I can repeat the differentials for peripheral neuropathy, diabetes, uremia, alcohol, drugs, vitamin B12 deficiency, vasculitis, autoimmune, amyloidosis, sarcoidosis, HIV, leprosy, hypothyroidism, paraneoplastic, multiple myeloma. This is the whole differential. Okay, right. The full analysis for the pain. After analysis of the pain, as we mentioned, the nature, the severity, the site of the pain, the radiation, any specific time of the day, anything can improve your condition, anything can يعني improve, anything can increase or aggravate your condition, and ask about claudication in any pain in the back of your legs while smoking. Ask about any night aggravation of your symptoms, restless leg syndrome. Okay, and ask about weakness, of course, any problem in the gait, as you mentioned, any problem in the gait, any weakness. Do you feel that you are walking in a cotton wool? يعني cotton. I gave you this positive also. Okay, walking on a cotton wool. This is a very يعني characteristic for peripheral neuropathy. Walking on a cotton wool. Yes. Any are you unsteady at all? And you mentioned this. Okay. Right. Then you can cover some of the questions of the CNS, like in headache, vision problems, is it يعني involving your hands as well, and you asked this and I gave it positive for you. Okay, يعني hands also affected. Okay, any trauma to your back, and I think you mentioned or mentioned something about back pain or trauma to the back, exclude radiculopathy, Guillain-Barré, all of this. Okay, right. Then the general questions, يعني any weight loss, any problem in the appetite. Okay, I gave you weight loss because Addison have also weight loss. Okay, and you didn't ask if it's intentional or not. Very, very important. I will tell you it's not intentional. Any change in your appetite? Yes, there is a change, because some conditions there is weight loss without problem in the appetite, like celiac, malabsorption. They have weight loss without problem in the appetite. They are eating very well, but because of the malabsorption, they are losing weight. And also thyrotoxicosis. Okay, there is weight loss without problem in the appetite. Other conditions, chronic infections, cancers, and chronic conditions, there is weight loss with a change in the appetite. Okay, right. Yeah. Then bumps or lumps, then you should cover in the female young age autoimmune questions, as you mentioned, joint pain, skin rash, any change in the color of your skin, any dizziness while standing up from sitting position. I will give you those positive for you. Okay, because it's mostly pernicious associated with Addison. Okay, pernicious associated with Addison. Okay, then female history. I should give you that. يعني it would better for me if I gave it the period has stopped. Okay, because premature ovarian failure may be associated as autoimmune. Okay, then asking the smoking, alcohol history is very, very, and you can cover the مثلا uremia. Okay, uremia. You can cover the kidney questions, very important in this case. Okay, And diet, yes, and the GIT questions very, very important. Ask about the diet. Are you vegans or vegetarian? Very, very important. Are you taking balanced diet, including the milk, vegetables, and meat products? Okay, to exclude this. And also, do you have any malabsorption? Malabsorption conditions like Crohn's or chronic pancreatitis can associated with this vitamin B12 deficiency. Any surgeries, like any bariatric surgery, gastrectomy, or any ileal resection can also associated with vitamin B12 deficiency. Okay, these questions for for vitamin B12 in specific. Then GI symptoms very important. Kidney problems also to exclude. Any past medical history, any diabetes in specific, and you ask this, okay, to exclude diabetes because it's very related to peripheral neuropathy. Okay, then we can go to the examination. How you can examine your patient? You didn't examine generally. Generally, I would give you that there is pallor. Pallor would guide you. I was going to give you pallor is positive, okay? And also exclude any glossitis, any if Mustang, I think, any these associated conditions with the pernicious anemia, okay? Or any vitamin B12, I think, deficiency. Then you can examine the abdomen and neurologically as you examined. You can examine the legs neurologically to empower reflex coordination sensation. And I will discuss what you will find in neurological examination of the legs. You can examine the Romberg and the gait as you did. Very, very nice. What is remaining for you? The general examination and the abdomen examination. Okay, abdominal examination, very important. Is there any scars, any previous operations, any masses? Okay, because the case here related to the pernicious anemia, antibodies against antiparietal and anti-intrinsic factors. So it's a GIT and the neurological, both of them. Okay. This is a full exam. What we will find in neurological examination by inspection, you will not find anything. Okay, tone, hypotonia, hyporeflexia, mixed upper and lower hypotonia, hyporeflexia, upgoing planters or extensor planters with absent ankle reflex, and the knee reflex would be jerk. Something like that, mixed upper and lower motor neuron lesions associated with the superficial sensation is lost up to the knees. This going with peripheral neuropathy, and the deep sensations, vibration up to above the anterior superior iliac spine, going with the dorsal column affection or posterior column affection. Okay, so you will find mixed upper and lower motor neuron lesion associated with peripheral neuropathy and also posterior column affection. My first differential goes with subacute combined degeneration of the spinal cord. Okay, it may be related to pernicious anemia as autoimmune conditions associated with Addison and premature ovarian failure. This is a full diagnosis. Yes, and this is the case. If we went through the further discussion, what will be the investigations and treatment work up for the case? Okay, give me seconds for that.
Claudine, I have a question. Why patient having living at the clavicle?
Yes, because you will go through the is there any loss of the four modalities of sensation, okay, below the level of anterior superior iliac spine? This is goes with peripheral neuropathy only. Okay, if you find the deep sensations, including especially the vibration, because proprioceptions will not guide you to the level of the lesion, but vibration you should in the exam. This is advice in the exam. According to Dr. Salah, go first for vibration, because vibration will lead you to the level of the lesion. If the level of the deep sensation affection above to the level of anterior superior iliac spine, this is posterior column or dorsal column affection, also with peripheral neuropathy. And I gave him Romberg test is positive. Okay, so the patient have both of them, peripheral neuropathy with dorsal column affection or posterior column affection with mixed upper and lower motor neuron lesion. This is يعني also clinical neurological case. Okay. Yes.
Yeah, my question, dorsal column affection at the level of thoracic, for example?
Yes, above anterior superior iliac spine goes with the posterior column. Below that, it will be peripheral neuropathy only. Yes. I gave it يعني for him as a clue to identify there is يعني also sensory ataxia regarding the posterior column affection. يعني I only gave that for him for as a clue. Okay. Yeah, الورك اب بقى والتريتمنت. Okay, how we can يعني what's the work up and what's the treatment. Okay.
Hello.
Yes.
Dr. Dahlia, can you please make it clear because I could not get it. How come till anterior superior iliac spine is posterior column and before that it's peripheral neuropathy?
Yes, deep sensation, vibration, and the proprioception. This is يعني ايه we can know the condition of deep sensation from both of them. Okay, I will in the exam I will start with mine, Dina. I will start with vibration because vibration. I will use the tuning fork until I know the level of the lesion. If the level of the lesion, according to Dr. Salah, this is not my يعني this is not from me. Okay, if the lesion of vibration sense affected below the level of anterior superior iliac spine, this is goes with peripheral neuropathy. So you can say that there is affection of 4 modalities of sensation, superficial and deep sensation, up to the knees, like glove stock distribution. Did you get my point? Up to the knees, up to the any level below the anterior superior iliac spine. If the deep sensation is affected above the level of anterior superior iliac spine, this is more affection of the posterior column. And both of them يعني identified as sensory ataxia. Sensory ataxia may be central in the posterior column affection and may be peripheral neuropathy. Right or wrong?
Yeah.
Yeah.
Sure. Yes. Nice case. Yeah, and the workup,
No,
can you...
Doctor, wait, please, because it's not clear for me till now, Dr. Dina.
No,
The
Dr.
dorsal column.
So the sensations are divided here. So we have the deep,
Yeah,
which
it's
is
peripheral.
the
Okay, I agree. Even the subacute combined degeneration affection, it will be scattered areas. It's not a major cut of the dorsal
Yes,
column.
I agree with Dr. Basim. Yes, I agree with
So
Dr.
how I
Basim.
will have level up to the clavicle without affection of the other? That's why I need also opinion from Dr. Rabia. Can this happen? We find peripheral neuropathy with
No,
the
very
level.
difficult because for me it's for the first time I'm hearing this because posterior column I agree. I think Dr. Dahlia is trying to say what I understood is that if the lesion is extensive involving posterior column, it can extend up to anterior superior iliac spine. Usually peripheral neuropathy is up to glove and stocking, but how come peripheral neuropathy will present with joint position and vibration loss? I'm sorry, Amalai, this is very difficult for me to understand. I'm a neurologist, but I did not hear about this before. So if it's affecting the clavicle, it should affect the wallahi. Dr. Dali, I'm sorry, I could not understand this, wallahi.
Yeah, you are a neurologist.
Yes, Dr. Dahlia.
I wrote the case after Dr. Salah. I actually took a clinical course with him. Okay, so it's not my يعني my from
yes,
my
I know you are right. But for me, I don't understand it. It's okay. I understand that it's from Dr. Salah.
The deep sensation, if the deep sensation affected below in the low levels, like up to the knees, you can say that this is glove and stock distribution of the 4 modalities of sensation are lost in a glove stock distribution. This goes with peripheral neuropathy only. Okay, if the deep sensations is affected in the يعني two upper levels, he said that it goes more with the posterior column affection. Okay, I know it's يعني difficult case, but it's
Tamam, okay. I got it, Dr. Dahlia. I agree. I do not agree, but I got it what you are trying to say. Tamam, I agree. If it's just simple, till the knee, it should be peripheral neuropathy. But if extended to the anterior superior iliac spine, it's something involving the posterior column.
Yes.
Dr. Rabia, can it be the subacute combined degeneration? It's known, I think, that it may progress and then it involves higher levels. So in this case, it is involving the spinal cord as subacute combined degeneration. And because it affects more, I think, the dorsal, right? More than the anterior.
Yes, true.
Yes.
It affects the dorsal column more.
Well, that makes sense, I think, in this case. That's what's happening. The anterior is still peripheral.
Safe, yeah.
I think the case was clear that it's peripheral neuropathy. Can we agree with that? And also,
This one
Dr.
would be
Dina,
easy, yeah.
it is not pure peripheral neuropathy. This is
Yeah.
upper motor neuron lesions, pyramidal shape of weakness, which is examined. That is why extensor plantar is positive, plus dorsum affection, plus peripheral neuropathy. For differential diagnosis, the top of differential, subacute combined degeneration, then the others with like periodic ataxia, again is that lab and lab. MS again is that peripheral neuropathy is there like
Yes.
this, I think.
Exactly, yeah, mix it upper and lower. When you find blunder upgoing with hypotonia, hyporeflexia, ankle jerk is ankle reflex is absent ankle reflex with blunder upgoing, this is mixed.
So what are the differentials of the mixed pattern? There are, I think, 5 typical.
I can revise them with you. Friedrich's ataxia, okay, subacute combined degeneration, syringomyelia, tapes dorsalis, and the conus medullaris, and the combined lesion, like any stroke with diabetes, any MS with diabetes, like that.
They like that in the exam, I think. And they brought tapes dorsalis, I think, right? In one of the diets.
Tapes dorsalis came? Oh my God, I don't know.
So you mean transverse myelitis, Dr. Abdullah? I guess tapes dorsalis didn't come before.
Okay.
Syphilis as a tertiary and in this level of affection of neuro, very difficult and very rare case. Okay, thanks Dr. Dina for the case, and thanks Dr. Abdullah. Well done related to the time management today, much better because always you are finishing before the time, sorry, after the time, but today you try today to do your best, but still some system review you didn't did. For example, the GI, the genitourinary, the endocrine, and the joint, the skin.
Yes.
You didn't ask all these systems.
Oh, I asked about
anyway,
and
you asked about the joint?
Yeah, the joint and the thyroid. I covered, I think, the thyroid, tried to cover the thyroid, hyperthyroidism, but hypo is...
Okay, so I will comment from the start. You talk around 5 minutes analyzing the pain or the leg pain, which is in this case, yeah, it needs because it's difficult one and still not well organized pain. You don't know what is the nature, so that's why you talk long. You didn't ask about the nature, and that's the reason behind taking long for analyzing it. Previous, you asked for the previous attack, the onset course duration, the side, which side on and off, which worse, which improve, the scale of the pain you didn't mention at all. It's very important. And you offer for painkiller, but you didn't scale the pain from 0 to 10. When 0 is no pain and 10 is the maximum. The improvement and worse, the swelling, claudication, you didn't ask. The timing, what time exactly you asked. Is there any weakness and you found there is weakness till the extent that she got sick leave for many days because of the weakness. And lately she told you that she's like feeling walking on cotton wool. Means that peripheral neuropathy. You analyze the CNS again for facial dropping, tingling, numbness in the hand. You can also add the balance, very important here, the balance and the hearing, the vision. You ask for the vision. Still, you ask for the swallowing difficulty, speech, headache, and yeah, the control of the water work and back passage. You analyze the CNS in general and all. You did it well, but it takes long. And you took the time for them and you miss the time for other system which might be important like GI, for example. If you have gastroenteritis features and you have patient with these features, you can think about Guillain-Barré or ITP or sorry, TTP, some CNS patient with related to, or hemolytic uremic syndrome related to the GI. Also, acute intermittent porphyria, but this will be chronic one. Okay, let's go back to the female history. It was weird. There was some change at the period, which is distracted you here also. You think about endocrine, the timing of the period, the use of birth control pills. You ask for that. You can also think about stroke or mini stroke. However, no lateralizing signs here. Family history, you ask the travel, the medical history, you did great about high blood sugar, high blood pressure, medical allergy, surgical you didn't ask, and the trauma you asked lately. HIV package, you didn't ask. The alcohol is very important, and the smoking, alcohol here very important for autonomic neuropathy. But I guess the amount wasn't significant. I am not sure how many alcohol he is drinking. I guess it was in the weekend. So
It was
I don't know.
one
It
to
was how
two
much?
glass, 1 to 2 glass per
cups.
month.
2
Per
glasses.
month?
Yes.
Per month,
She
2
mentioned
glasses per month?
Per day, per
she
day.
mentioned 2 glasses in week.
In per day. He asked me per day, 1 to 2 glass
In
per.
So it's significant or no? Because this, I guess this amount
No,
is not
glass,
significant.
not unit. I think it is significant because the glass is not unit. Okay, you can count it in units. It's significant.
If
So
you
and even
if you
it's not significant up to مثلا 12 units, 14 units, she should stop because she has another condition and this will aggravate her condition. So I should advise her about stopping alcoholism, and they can put it also in the differentials of the peripheral neuropathy, okay, because of alcoholic use, okay?
you should know the type of the alcohol. If it is beer, the percentage of the alcohol is less than much less than of the spirit drinks, like other types of heavy alcohol concentration. So when the patients say, or surrogate say, I drink alcohol, you may ask him about the types of alcohol. This is spirits, wine, or beer, because there is a difference in the units and the concentration. And the female, I think 13 units per week it is allowed, and for male 14 units per week. It's just for remaining.
Okay, Dr. Hassanin, if you have a simple formula to
yes,
calculate the units, yeah, please
yes,
share it to the group.
yes,
please.
yes,
Because
I will share it. Yes,
yeah, thank you so much. I appreciate it. Okay, then you can put still the alcohol peripheral neuropathy as a differential, and you should advise immediately about that. The driving and the job you did great about them. The examination very important in this patient. CNS full neurological examination you will do, starting from pronator drift or the hand to roll out stroke, and then the power, tone, reflexes, coordination, sensation, and all was impaired. The dizziness, you did it well after sitting, standing, blood pressure, and the gait, Romberg test. I think you did everything in the CNS examination, but the case was difficult. Honestly, the case
yes,
is
difficult
difficult to
case.
be, yeah, mix it from
Difficult,
upper and
yes.
lower, how to
If we,
correlate this. Yeah, it's especially chronic one. If acute, you can put, yes, Guillain-Barré, some methania, stroke with MS.
hypokalemic hemorrhagic paralysis, yes.
Yeah. So the constitutional symptoms you asked, the loss of weight, 7 kilograms over 6 weeks or 6 months. The tiredness also was there. According to Dr. Dina, there was diarrhea, but you didn't ask in the in gastroenteritis. That's why, or gastroenterology or GI system. That's why you didn't catch the Addison. And it will also be in the differential for the peripheral neuropathy, along with vitamin B12 deficiency. This is the underlying cause of the anemia. The pallor, the jaundice, the sweating, the sweating you asked for the lymph node, and the fever you didn't ask. So the differential in this case will start by subacute combined degeneration, yeah, as mixed upper and lower, peripheral neuropathy due to anemia, the same finding or the same reason of vitamin deficiency, and I still thinking about chronic inflammatory demyelinating polyneuropathy. However, it's, yeah, Dr. Medina said it's not motor, but I think it affects both
Yeah, can
motor,
affect both. Yeah.
yeah, the nerves and
Probably.
motor, or yeah, either motor or
Yes,
our sensory.
CIDP, motor and sensory,
Yeah,
CIDP.
especially
Yes,
it's chronic cause. The one I
but
can add, but no family history here.
Friedreich
You
attacks.
can Friedreich
Yes,
ataxia and what
no
else?
family. Charcot-Marie
Yeah,
tooth disease, because
Charcot-Marie-Tooth.
there is no family.
Excellent.
Yes,
Yes, exactly.
yes,
Excellent.
yes. Actually, I have some point, Dr.
Yes,
Basim.
Dr. Abdul.
If you finish,
Yeah, I'm done.
thank
I'm
you.
sorry, Dr. Hassanin, just a small question. You said Charcot-Marie tooth, guys. Charcot-Marie tooth doesn't lead to this pattern absent and
Yes,
There
yes,
is two
against.
types. There is two types of
Yes.
Charcot-Marie-Tooth. There is sensory one and motor one. So we can think still about the
I mean
either
doesn't lead to the absent and
Sensor.
preserved
Yes, yes.
reflexes.
I'm with you.
Yeah.
With you both. Yes, I'm with you both. Actually, the Charcot-Marie tooth disease, we can put it in the differential, but we should mention that what's against it. Actually, the extensor plantar against Charcot-Marie tooth disease, but it is really with the sensor ataxia and motor peripheral neuropathy. But the extensor plantars against it, and we can put it in the bottom of the differential. Actually, this is a difficult case because the beginning of the scenario, starting with leg pain. Leg pain, actually, when I read or when the patient started the chief complaint with leg pain and weakness, I put the musculoskeletals like the muscular dermatomyositis, polymyositis, and secondary causes of myopathy because there is pain and weakness. And also I put the peripheral vascular disease. But when the scenario comes on and continue, the patient said she has a difficulty in walking as she walk on cotton wool. We should exclude these differentials. I didn't hear the candidate ask about proximal myopathy, like standing from the sitting position difficulties or from squatting position. It is a difficult case, yes. But when you continue on the scenario, on the examination, there is Polar, there is Romberg test positive, so the differential is narrowing now. Regarding a differential diagnosis, yes, it is a subacute combined degeneration of the cord. Number two, when there is leg pain and sensor ataxia, sensor plantars, peripheral neuropathy, I think the second and most important second one, it is tabs dorsalis, because tabs dorsalis typically present with lancinating, called lancinating pain in the leg, lancinating pain in the leg. So we need to explore more about sexual history. And I should remind my friend, the doctor who make a candidate role, to ask sensitively about the sexual history. Even you said you are married, you should ask this sensitively. Like this, if you don't mind, I want to ask you some private question. Is that okay with you? So, are you married? So, do you have any other casual sexual activity? Do your partner has any sexual transmitted disease? If said she has previous syphilis and there is lancinating leg pain, with this feature, we will cast the diagnosis, and this is tabs dorsalis. So in any way, the case is difficult, and the performance of the candidate and the surrogate is very good, and thank you.
Thanks, Dr. Hassanin. Actually, your voice looks like Dr. Abdullah sound. So I don't know how to differentiate
No,
between
no,
both. Yeah.
no, thank you,
Okay.
thank you,
Thank you, Dr. Hassan. Thank you for this
thank you,
comment.
thank you.
Okay, thanks, Dr. Abdullah, Dr. Dina. We have exciting news. Dr. Imaz with us after the exam. Dr. Imaz, we can give you the mic to give us the all feedback for the exam. It was fresh exam just today. Are you with us, Dr. Imaz?
Yes, I am. Assalamu
Yeah,
alaikum.
welcome. Alaikum assalam wa rahmatullah. So the mic with you till the end of this session. No communication today. We will hear your experience today because you were
I can give
attending
you a
with us
brief.
for the last 2 weeks. Yeah,
I
do
can
it.
give you a brief. It wasn't a lot of things, to be honest. I can give you a brief, and you can still continue the communication, I hope.
No. Anyway, I don't have Candid with me, so I want to listen to your practice. It's very important, and
Okay.
yeah, please
Okay.
do.
So it was so I started with the station number 5. It was my first station, and I just it felt the exam was I think 2 hours or less, but it felt like no time. Like after I finished, I was supposed to leave, but I didn't know that we finished. I was going to move to the next room because I thought we still have more patients to do. So anyway, cut the long story short, the first station was consultation, and my patient had it was a lady who came with shortness of breath. So from outside, shortness of breath, and being unwell for 3 weeks. When I had a look at the OPS, she was like 40 years old, female, and the OPS was that she was tachypneic, respiratory rate of 22, SATs were 92% on room air, blood pressure was okay, but she was tachycardic as well, 110. And temperature was 37.5. So from inside, when I asked the patient about what was going on with her, she mentioned that she gave birth recently, so like 6 weeks ago, I think, and that she had this breathlessness before giving birth. So anyway, no neck swelling, no ankle swelling, no yes, no ankle swelling, no paroxysmal nocturnal dyspnea, no dyspnea when lying flat. It's just dyspnea when she's trying to move from one place to another, and it's getting worse. And she's been unwell. So it was about PE. She doesn't have any family history of anything, or she doesn't have a history of anything. She just takes fluoxetine. So it was PE simply. They asked me what else could you put differential looking at what she have, and I just tried to put the peripartum heart failure because she had the exertional dyspnea before giving birth. And it went smoothly, alhamdulillah. It wasn't bad. They asked me about the VQ scan and the CTPA and all this stuff. She yeah, so I said that she needs to be admitted, and that she's desaturating, basically. She's dyspneic, tachypneic and desaturating hypoxic. She will need anticoagulation, and we need to do a VQ scan because she's breastfeeding. And what else was supposed? Oh yeah, discuss with the patient the possibility of anticoagulation if the scan came back positive. And I think that was it. They asked me too many questions, and he was so fast in asking me these questions. And then I moved to the station after that, and it was station 1.
Did he mention the echo, or did he ask about the echo and
I
the importance?
mentioned the echo.
Excellent.
I mentioned the
Yeah,
echo.
excellent.
Yeah. I mentioned all
Okay.
the investigations, and I mentioned anticoagulation, and mentioned
Yeah. So he means
if
by
there is any
anticoagulation that,
hemodynamic. I'm sorry?
yeah, he mentioned the anticoagulation in the form of provoked or unprovoked
He asked
PE,
me for
right?
how long. He said, you
Yeah,
want to start anticoagulation, and I said minimum 3 to 6 months, and then we will reassess her, and if she needs to be anticoagulated for more, we need to involve the hematology
yeah,
and all that.
excellent.
also, I'm trying to remember. But yeah, I think that was mainly the question that he asked me. He said, "What do you need to see in the echo?" And I said, "A bedside echo, just to look at the right side heart strain and right side heart failure."
Excellent. Yeah, excellent.
This went smoothly, alhamdulillah. And then the next station, what was the first station? Number one?
PE.
No, number one. So this was number 5, was consultation.
Okay. The short, you mean short?
I
Heart,
think it
cardiac,
was, I think it
chest,
was,
and communication,
it
abdomen
was
and
communication
communication.
and chest. And he
Yeah.
was a 60 years old with new diagnosis of PE. It was mainly, this exam was cardiovascular. Patient had PE, was started in enoxaparin, had adjusted dose because he have end-stage renal failure. They can't start him on the WAC, so they're gonna start him on warfarin, and he obviously not gonna like the warfarin. He said it's a rat poison and he doesn't want it. So I've spoken to him about his kidney function and that the hematologist had a look, and the hematologist advised this is best for him. It's gonna be monitored. He's not gonna have bleeding, so the risk of bleeding should be less. And we talked about his kidney function, make everything, the options that we have limited, and we usually go to
Yeah.
hematology to help us in
Excellent.
complicated cases like his. And I think, yeah, basically that was his concern. He asked me about flying, and I said, I have no idea. I need to check and come back to you. I will speak to my consultant, but I don't know. I don't really know. PE people, do we stop them from flying?
I just know
I
unless
said, if you're
there is
unwell
DVT. Yeah.
now, I said if you're
If there is
unwell now,
DVT.
maybe delay it, but we will need to check with. I will
Yeah.
need to check
Yeah.
with the consultant, and I need to check the website to just see
Yeah. This
if
is the best answer. Be diplomatic if you don't know. But I guess
But
there
I
is
think
relation.
yes, long flight يعني she
Yes,
will know.
exactly.
It's
no,
not
I
Me too.
advise against long flights because he had it after a long flight. He had it after a long flight, so I explained that you should
yeah,
avoid
any
long flights
flight.
and.
Dr. Rimat, she is unstable condition. You mentioned desaturated and
Oh no,
hypoxic.
that's a different patient. This is a communication.
Yeah.
Ah,
This is the communication.
yes, she has liability. I think she can take prophylaxis or something like that. I don't know because she has liability for thrombophilic condition يعني صح؟
No, it will be taking history. You'll not ask about these things. Anyway, the best answer is yes. According, I will ask my senior, or we can review it with my consultant. Then I will be back with you. Actually, I'm not sure, but at least should be anticoagulated for some times. For how long? I'm not sure. So the best answer, be diplomatic in such cases. I don't. I will ask my senior, then I will update you. That's it. It will not harm
Sorry,
you, and yeah.
sorry. What is the point you
Yeah,
now discussed
PE
about what?
patient with
Yes.
anticoagulation. Sorry, valvular heart, Dr. Rimaz, valvular heart or PE. It
Yes.
was something need anticoagulation. Patient need anticoagulation, and he's not happy
Mm.
about warfarin. So he asked her about travel or flight. Is it allowed or no? And she said, I will ask my senior or my consultant, then I will be back to
Mm.
update you.
Mhm. Actually,
So
actually,
yeah.
yes. Actually, in the acute pulmonary embolism, I think, but I don't sure the flight for 2 weeks. After that, the patient will be evaluated by cardiopulmonary exercise testing and echo study and ECG and SpO2 saturation. I think 2 weeks. 2 weeks, if I
Yeah,
didn't
that's why
wrong.
still
Mm.
still it's not sure, Dr. Hassan.
Yes,
Always
yes,
we
yes,
have a rule. Since you
yes.
are not sure about time frame, don't
I
mention
will.
it. Be
Yes, I
yeah,
will. I will ask my consultant. I will give
yeah,
return
I will
back to
give
you
you.
with the answer. Yes,
Yes, excellent. Yeah, this is the best
yes,
answer ever. In any
yes.
case scenario of driving or flight or pilot or something related to time frame detection. So better, yeah, better to say like that. Then Dr. Rimaz, other concern. Sorry, Dr. Rimaz, are you there? So let's talk about the anticoagulant in kidney patients until Dr. Rimaz will join back. Yeah, as Dr. Rimaz said, the being in kidney failure or kidney non-functioning well, as per simple word. So the choice is being limited, and we don't have a lot of choices. So what we can do is the best choice here is the warfarin, according to the consultant or according to your task even. It's your task
Assalamu
to talk
alaikum. I'm
about.
sorry.
Alaikum
I'm
salam.
sorry. Just جتني
No,
مكالمة
it's
بس.
okay. Okay, go ahead.
طيب.
Continue talking. Yeah,
طيب this was the communication. It wasn't bad.
yeah, good. So
Yeah.
no option about DUAC, direct oral anticoagulant.
No,
It's
because
only warfarin.
his kidney function,
Yeah.
his end-stage
So
renal
it
disease.
wasn't written. So you will not raise it at all. It
No,
wasn't
no,
written,
not at
right?
all. No.
Okay. Okay, go ahead.
Yeah.
The concern about the patient, sorry, about the concern from the patient.
The
Any
concern was
concern?
that do I need to take this medication and I'm going to bleed and die? He had an ulcer, bleeding ulcer, um, um, 10 years ago, gastric ulcer, because of alcohol.
Anyway,
And
you will,
he
yeah.
drinks 50 units. Oh yeah, he drinks 50 units of alcohol per week.
We just mentioned revision. Remember the alcohol, the warfarin with the, sorry, the warfarin with the liver disease or the warfarin interaction. It wasn't
No,
warfarin.
he
It was
didn't have liver disease. He just drinks a lot. So I asked him to stop
yeah.
drinking.
But there is also
I said if you struggle, we can refer you to the alcohol liaison team.
yeah, and there is also some vegetables or some fruits.
Yes. So I said we will
Yeah,
give you
some
leaflet.
diet, I mean. Yeah,
Exactly. Yes. So I said we will give you leaflet about the medications and the food that you can eat and cannot eat and all these things.
yeah, great. Okay. Okay, then the short chest.
And then the chest was very weird. The patient from the end of the bed had a chesty cough. On examination, nothing, no crackles, nothing on the chest.
So what do you think if you have patient
It
with
can
this?
be pneumonia or bronchiectasis.
Or bronchitis, yes, and the secretion
Yeah,
are not there. Yeah.
exactly. So I just no, she didn't have wheezes, and looking at the way she was coughing, I think they brought her from the
Yes,
hospital, like she was admitted
yes.
actually.
I think yeah.
So I just told them that I think from the way she coughs that she had.
Hello, Dr. Imaz. We can't hear you if you are talking.
I couldn't take history to know if it's dry or the cough, whether it's dry.
Yeah. You can't take you cannot take history. Yes, you're right.
No, because somebody asked me, somebody asked me.
Center.
Yeah.
I mean, sometimes there is a sputum put beside the patient, or
No, there was nothing.
guidance. Yeah, yes. Yeah, and I was asking any cannula, like any to exclude pneumonia. I think is sometimes they have cannula or any
No,
guiding
nothing. The patient didn't have anything.
anything.
So
No.
Dr. Imaz, sometimes they are bringing bronchitis after the course of antibiotics, and he get better, and they just provide the patient to you, and you will not find anything in the examination. So he is bronchitis,
Exactly.
but
So the discussion was about
yeah,
the bronchiectasis. So he asked me,
yeah,
the patient
yeah.
had a cough. From the nature of the cough, what do you think she had? And I just said that I think she might have. It can be just obstructive, so can be bronchiectasis or pneumonia. Looking at the fact that she got like there are no crackles. And yes, that was it really.
Yeah, so mostly bronchitis, as you said.
Yeah,
Yeah, great.
so the discussion was about bronchiectasis.
Yeah, it's clear. And
Something
the
else.
vaccination and so on, you mentioned. We'll
Yes,
talk
so he
about
asked me
bronchitis.
about the management plans. We talk about everything.
Excellent, excellent. Yes. So till now, the 3 stations in your bucket. The next, inshallah, hopefully. Hello?
Actually, just came home, so I'm so tired. The station after that was station number 2, and it was clinical consultation, and it was very weird because it was a surrogate. But usually, even if it's a surrogate, they will let you examine the surrogate. So no, but the patient was sitting on a chair. There was nobody in that room, and she was a doctor, the surrogate. She wouldn't let you examine her. And she had a collapse. So it was a little bit weird.
Collapse as a syncope, you mean?
No, she just had that. She said collapse, and then when she inside, it sounds like a vasovagal. But I just needed to rule out the epilepsy, the cardiovascular, because she had a family
Yeah,
history of sudden
yeah.
cardiac death.
Excellent.
Yeah. So we ruled all the red flags and the serious things, and the discussion was about vasovagal and cardiac syncope and congenital, like, the inherited cardiac disease.
Excellent. The red
And then,
flags as well.
yeah, I didn't know what to examine. I examined the cardiovascular and examined vision. They had the fundoscopy there. So after they set time up, I said, I would like to do a fundoscopy because if I had to do
Excellent.
fundoscopy, what would I do?
But I heard, Dr. Rimaz, that they canceled the fundoscopy from the UK cases.
I
don't
hope
know.
so, but there was a fundoscope there. There was
But Dr. Maz was so smart. She offered after the time finished.
the times up, yes.
Yeah, the best way to offer.
She found fundus, so she asked for fundoscopy because I found that there. What is this instrument for?
Why is it here? Like, what do you want me to do with it? The patient didn't have any, and when I saw the fundoscopy, I was like, did you have any vomiting? No. Any, like any signs of increase in temperature? No. I did the eye movement examination, nothing.
Any
So
complication, any long QT, family history of
the
cardiac.
the patient was on fluoxetine.
Fluoxetine,
So
yes.
I was like, maybe
Yeah.
I put it in the, oh my God, that's so scary. Sorry. So I put it in the differential, and I said, maybe she have, I'll need an ECG to look for any arrhythmias, long QT or something. She have her uncle passed away at the age of 40, and she's 40 now. So maybe she have hookah or something. So just talked about all these investigations. And then the station after that, station 3, it was so scary, guys. Oh my God. Neuro and cardio. The cardio was okay. It was a metallic aortic valve replacement. The patient had hypercoagulation. She got bruises all over. He wouldn't let me finish. He just started asking me questions. So I was like presenting, and I was like, I couldn't appreciate any signs of heart failure. He's like, okay, what about the things in her hand? I was like, yeah, there is bruises. It's over coagulation. There's no heart failure. I wanted to say infective endocarditis. He said, what if she came with fever? I was like, I wish if he give me the chance to complete my presentation, but he didn't. So anyway,
no exam without infective endocarditis in cardiac station.
Exactly. And he asked me about infective endocarditis, very detailed question. The neuro, I think it went well, but the neuro was crazy. The patient had a walking stick, and they said this patient came with walking difficulty. Can you examine the upper limbs? On examination of the upper limbs, he had very vague symptoms. He kept helping me with the tone. I didn't know whether it was hypertonic or hypotonic. He kept helping me with the reflex. I was like, just relax. He wouldn't relax. I couldn't tell what is true and what is not. He had power problems, loss of sensation. Huh?
What is the age?
He's like 60s or maybe early 70s. The good thing is I exposed the arms till the shoulder, and I saw a device, a diabetes blood sugar measuring device. So
Oh,
yes, so I was like, oh my God, what's that? I couldn't even remember. It didn't come to my mind at that point. He said, you looked at something and you pointed at it. What do you think this is? And I said, I think it's
oh,
a device to measure the blood sugar. And he said, okay, why? What does that make any sense? I was like, yeah, it looks like neuropathy, diabetic neuropathy. The
yeah.
symptoms doesn't make sense because hypertonia, hypotonia. I didn't know what was the tone, and I told him that I didn't know what was the tone. Um, so yeah, okay,
Sensation.
guys,
What
can
about sensation modalities? Did you do?
so he had loss of vibration. Can you
So
guys
it's
just give me
clear now.
1 minute? Just 1 minute, sorry.
Yeah,
We have to
at least.
just
Yeah.
1 minute.
So it was distribution like gloves.
Yes, it was like gloves, and he had the weakness in the hands.
Yeah. So it's clearly now it's diabetic neuropathy or peripheral neuropathy due to diabetes. Yeah. Even if didn't mention Dr. Imad, are you there?
Yes, she mentioned يعني she will go for a while and come back.
Okay. So I guess it's peripheral neuropathy, and even if you didn't mention the differential clearly, but you mentioned the diabetic as underlying cause, I guess you will get the mark. And you did all the stations great. Hopefully you'll pass, Dr. Imad, inshallah. Okay. Till Dr. Imad will join. I think, yeah, the most common and famous scenarios came today with Dr. Imad. From the bronchiectasis, peripheral neuropathy, valve replacement, either aortic or mitral. Even the long scenarios, what was about a PE. It's very nice exam. And the communication as well, it was also about counseling, about anticoagulants. Yeah, I guess it's good one. And hopefully Dr. Imaz will do it, inshallah. Soon we'll hear this news, Dr. Imaz. I hope you can hear us. Okay, any question related to our topic today or our cases, the long, I mean? Let's read the comments. Long time I didn't read. Frederick, this start from alcohol. Dr. Abdullah, hot, hot care, yes, important, including multi-step simulating approach. Okay. Dr. Nada write a question or wrote a question. Superficial sensation can determine if peripheral neuropathy or not. Yes, of course, Dr. Nada. Peripheral neuropathy, if the level at gloves and stock distribution, this is clear for peripheral neuropathy. So the peripheral neuropathy mean the level till peripheral. The word of peripheral neuropathy, the level at the anterior superior iliac spine. Above this level, it will be sensory level, and it will be totally different pathology. Sensory level mean that there is some disc or some vertebral injury, trauma, or transection or spinal cord injury, spinal cord infarction, vasculitis, cancer, infection, metastasis, TB, any level or any vertebral affection by any pathology. It will do what's called sensory level. What the sensory level, you have a lesion or sensation with level from either the clavicle downward till the anterior superior iliac spine. Below the anterior superior iliac spine, it's called peripheral neuropathy. The same for the arm. The arm below the acromion, it will be peripheral neuropathy, and above it, it will be related to sensory level, and it will be different pathology, which are vertebral causes, according to the level of the injury. Okay, let's go back to the comments. Above inferior separator means sensory level. Yes. Yeah, that's what I mean. Superior, yes. Detect the level. Foot Foot care here important, including muscular team approach. Yes, Buddhist for the legs and dropped or foot drop. You should call Buddhist or orthosis support the feet. Peripheral neuropathy has two types, small and large. In large type, it can affect the reflector level up to anticipatory recurrence. In spinal cord affection, there is sensory level, the lowest level up to the groin, not below this like sensory level in lower limb. So it has level above until yes, as I explained earlier. Should stop any type of alcohol in peripheral neuropathy. This Dr. Abdullah question. Alcohol also can cause vitamin D, yes, deficiency and lead to both. So let's talk about alcohol in paces. Alcohol in paces, if the amount more than 14 in any disease, you should advise to moderate 14 units per week. Moderate your alcohol intake. Okay, what if the disease related to the alcohol itself, like NASH? Sorry, like alcohol steatohepatitis, not NASH, not related to alcohol. So alcohol-related hepatitis, cirrhosis, any liver disease and paces, you should advise the patient to stop drinking. Any side effect of the dependency or the abuse of alcohol, you should stop. Toxicity, any suicidal attempt, you should ask to stop. And in this patient, also peripheral neuropathy or any cause related to alcohol intake, like vitamin deficiency as well, you can advise to stop alcohol totally. So any disease in spaces not related to alcohol and the patient taking more than 14 units, you should advise to moderate the alcohol. If not related to alcohol, any disease, for example, let's talk about myasthenia gravis. It's not related to alcohol. Or maybe myasthenia gravis related by nerves. Let's take another disease not related, like let's say ulcerative colitis. Okay, it's not related, so we can moderate. But if there is liver affection, you can ask. Rheumatoid arthritis, will you ask to stop or just moderate? Moderate if more than 14. But if liver hepatitis or liver cirrhosis, you should advise the patient to stop alcohol or to refer him if he is dependent. And if you have patient with alcohol abuse or dependency, you can ask for CAGE questionnaire. CAGE questionnaire for the cut down feeling annoying or other annoyed by his drinking, for A, G for feeling guilty, and I, eye opener to drink alcohol. If the patient has two or more, so he considered as dependent, and he should be referred to the team concerned for the dependency and how to cut down the drinking. Okay, let's go to a further comment. Alcohol also can cause, yes, Dr. Naz, I think
Yeah.
CIGB is not, yes, are you back?
Yes, I am. Yeah.
Yeah, I was just reading the comments in the chat. Okay, go ahead.
So we stopped في cardiovascular and the neuro, right? As I
Yeah,
said,
the
so the
neuro.
neuro was, he had to push me to say, to be honest, he had to push me for me to say diabetic neuropathy.
Yeah.
But then we went to the cardio and he was a little bit happier with me. And then I went to the next station, communication and abdomen. Oh my God. Okay, communication was okay. So the patient was 18 years old and he came with a collapse. He was seen by the cardiovascular, and the cardiovascular consultant said it's a vasovagal. I need to meet his mom and talk to her. Obviously, I'm not going to talk to her about drinking and alcohol abuse or anything. I just spoke to her about lifestyle change, drinking more fluids, and we will give him a leaflet explaining how to avoid these vehicles. And she said, "What should I do when it happens?" And I said, "Lift his leg up. If anything, if you felt he lost his consciousness, if you felt that it's just getting worse and worse, or there is anything scary." He had a seizure tonic-clonic. and I explained to her how. You can always seek medical advice. Call 999 for the ambulance and or bring him to the hospital. Otherwise, just follow the consultant advice, and he should grow out of it. You're always entitled of a second opinion if you felt that you're not happy. وكان كويس. مشينا للأبدومين يا جماعة. Young lady,
Okay,
35 years old,
Dr.
جاية
Remaz,
بأبدومينال.
the red flags, yes, it's you mentioned the red flag, right? Avoid standing in the hot
Oh yes,
weather,
yeah. All the
standing
safety
for longer
netting.
time.
Yes.
Yeah, safety
Yes.
netting and red flag. Yes.
All the
Okay.
dangerous activities, away from
Yes, the
fire,
hobbies, excellent.
avoid baths,
Yeah,
only showers and stuff like that. Driving also.
excellent. Yes.
Yes.
Okay. Then the abdomen. Yes, please.
The abdomen. Okay, it was a young lady, came with abdominal pain. She had a very big and deep scar starting from the just above the bladder, going up until it's almost a little bit below the civisternum. She had so many scars in her abdomen and so many scars in her hands. None of them was fistula. She had a small scar in her neck. I guess it was laparotomy, but she had a device in her abdomen with battery.
Pancreatic device, pancreatic transplant. Maybe.
The device was probably for diabetes.
Yeah.
Diabetic.
Morphine? Sorry, insulin pump?
No, I don't think it was an insulin pump. Maybe it was an insulin pump. Oh yes, I think it was an insulin pump. Either insulin pump or that device, the glucose measuring device.
I'm afraid
Yeah.
that she has a dual kidney and pancreatic transplantation.
She could have. And I said, to be honest, I could not appreciate anything. There is no transplanted kidney at all. I did deep palpation, superficial palpation, nothing. No transplanted kidney. I couldn't find any crayons or any tablets next to her. And she was very young. So he said the differential was like, this is a very difficult case. The differential can be anything. She could have had this surgery secondary to inflammatory bowel disease, and she have diabetes secondary to the steroids, or maybe just have diabetes with the IBD. It can also be kidney transplant secondary to being type 1 type 1 diabetes, having it since she was a child, and the kidneys failed and we replaced them. But I could not appreciate kidney. He said if she came with rearranged renal function test and fever, I said I would be worried about infection. I would be worried about rejection, chronic rejection. And he said, what are you going to do? Potassium is high. So I said, I will involve the renal team, blah, 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 blah. And he was like, what team are you going to involve? I was like, the renal team. Hyperkalemia management. It was simple things. He asked me about the device, and it was like the examiner was so angry. I was wondering, why was he so angry with me? It's like I actually killed someone of his family. He was so angry, with a very angry face. And when I went out, when I left the room, I asked my colleagues, the other candidate, I was like, guys, this guy looked like he's so disappointed on me, which made me more nervous. They said, this is how he looks. So he did the same to everyone.
Yes.
He did the same to everyone.
Something it's plays يعني psychological plays in the exam, don't you?
Why? But why would you make people's life
They
miserable?
are very, very mean, malignant people.
By the way, by
was
the way, Dr.
wondering.
Rimaz, yeah, don't judge on this. He might give you full mark, even by his look and by his
Yeah, subhanallah, I said to them before the
experience or
exam, I don't care if
expression.
I don't want someone to be nice to me and then fail me. You can be
Yeah,
rude as you can.
it's so frustrating when you face that someone is smiling and happy and so on, and
Yes,
finally he give you fail.
yes,
I hate that.
yes.
So just you can shout at me, you can do whatever you want. Just let
And
me
then
pass. I don't want to see you
yeah.
anymore. Yeah.
So my
Yeah.
advice to you guys, there is a very nice book that Ruda sent me. This book is so good. I think all of you should read this book. And I think this book, if you have like 1 month or 6 weeks before the exam, this book should be enough. I took it. She sent it to me a long time ago, to be honest. But I started reading it late. I will send it in the group now. Wallahi, it's very good. It has pictures. very helpful. It gives you a different perspective, because it shows you why are you doing everything. So you ask yourself some questions sometimes. Why am I doing this in there? Why do I
Yeah.
have to do this? And it just explains everything, even the different types of rashes, all these signs. I just read this book for the last, I would say, 7 days or more, and it was more than enough to me, to be honest. I'm just
Yeah.
gonna send it to you guys now in the group. Very,
Yeah.
very helpful.
Yeah. Hopefully, Dr. Imaz, you will do it.
Thanks a lot, Dr.
Inshallah.
Wallahi,
Yeah.
for
Please,
your
guys,
feedback.
dua.
Yeah.
Now, can you imagine the results are gonna be in August? I will have to wait for everyone in the
Oh
UK,
my God.
in Edinburgh, like the Edinburgh
Oh,
College. Everyone should have finished the exam. Then we will have our results. So till August.
so long.
We
Yani,
will keep
yeah.
dua in Arafah
Please,
Day and every day. You will
please,
pass, inshallah.
please, please, inshallah, and all of us, inshallah.
Yeah, you did a lot, Dr. Rimaz. You did a lot of effort with us in the group and in the practice. You were one of the expert and excellent candidate. I hope you will pass,
Thank you so
inshallah, this
much.
time. Yeah, don't
Jazakallah khair
worry.
wa jazakum,
Yeah,
all of you. Thank you, guys.
we'll pray for you. Yes, thank you for
Inshallah.
your experience and sharing it fresh the same day. And
Yeah, I literally
I
just
feel,
came from outside. Literally just
oh,
came.
thank you so much. Thank
Thank
you
you
for
so much,
giving
guys.
us your precious time. And
Thank you.
hopefully again, inshallah, you will do it. Thanks for the experience and sharing it again fresh with us.
Inshallah. Thank you so much.
Yeah,
Thank you, guys.
thank you, Dr. Imaz. Okay.
Bye.
Any question? Let's read the comment or
Does
question.
anyone
Wait,
have any
Dr.
question for me?
Yeah, I will see if maybe someone asked. Yeah, the book you will share, please. And
I
yeah,
think I
if
did send it now in the group.
yes, okay. Okay, so any question again? Wait, please. Nice. Dr. Hassanin, the first delay travel for 2 weeks. Yeah,
Oh
this
yes,
for
that I actually said that, and I wasn't sure. So I said 2 weeks, and I said I will check and get back to you.
yeah, good thing to mention. And
Yeah.
just to give him like a clue, just to prove, and I will be back to you. Okay. Peripheral neuropathy, motor sensory. What's the nature of the cough? What cough? Yeah, the
Oh, I
bronchitis, you
think they
mean? Yeah,
mean the cough in the
yeah,
respiratory.
and the
It
bronchitis,
sounded like
yes.
a pneumonia cough.
So pneumonia,
But
one of the differential of bronchitis still.
exactly, yeah.
Yeah, consolidation pneumonia and
But the patient
bronchitis
didn't
and
have any
pulmonary
crackles.
edema.
He didn't have
Yeah,
any
this is
crackles at all.
this explain it's not fibrosis. If fibrosis, the
Yeah.
crackle will, yeah, it
Oh
will
yes,
be
yes.
there. Okay, Dr. Abdullah also praying you will pass, inshallah, Dr. Imaz.
Inshallah, thank you.
Laparotomy, appendectomy, FMF. I don't think FMF will not do laparotomy as a major surgery. Laparo, FMF will come like appendectomy,
They
but
sometimes do laparotomy for them because they don't know what's
but
going
if
on. But that
yeah,
that doesn't explain the blood sugar
it's yeah,
thingy, the device.
yeah.
Yeah.
Maybe cystic fibrosis, yeah, for the pancreatic
She didn't have
complication,
clubbing. She
Crohn's.
didn't have
Or
any findings
any scar
peripherally.
in
Yeah,
the lower area, in the back, nephrotomy or nephrectomy, I mean, or
No,
something.
no scars in the abdomen. I examined the back. I examined the back. Let me show you how the scar is. So if these her shoulders, these are her hands,
Yes.
okay, and this is the umbilical. Scar was so thick, and it was like this.
Yeah,
So,
laboratory. Any other
and
scars?
device was here. She had so many tiny scars around. This device, this
yeah.
was the device, and it has a wire and it has a battery.
Okay, so this meaning, but you mentioned no kidney disease features. So we cannot say this is peritoneal dialysis.
No,
Maybe,
it doesn't.
yeah,
It was, there were tiny scars, not big like the peritoneal dialysis. You know, the peritoneal dialysis would be like this, something,
yeah,
a
bigger,
scratch,
yeah,
like a scratch, like line.
yeah.
But these were
So
dots.
yeah, so this is another advice for any candidate. Scars are very important in the exam. I remember I messaged you the day or before, 2 days before the exam. I told you read about the
Yes,
scars.
yes,
No
yes, you
exam
did.
without scar. Yeah,
Yes.
no exam without scar. And if you fail the scar name or the scar indication, I think you might fail the station. So the best thing is to read about the scar, especially in the abdomen. Abdomen station is common with the scar. Okay, any question, Dr. Ria? Which center? Center Edinburgh?
The Edinburgh is the Royal College, and the center was in Wales, Cumbrian,
Uh-huh.
a small
Okay.
town called Cumbrian in Wales.
Yeah. Yeah, all of us praying for you, Dr. Rimaz. You will pass hopefully,
Inshallah.
inshallah, and we'll pray for you in Arafah Day. Thanks, Dr. Rimaz, and
Inshallah. Thank you, guys.
please visit us always,
I
and
will.
yeah,
Inshallah.
let us hear your sound and your comments. You
Inshallah.
were one
Inshallah.
of the best candidates ever
No,
in the
wallahi,
practice.
you helped me a
Wallah.
lot. No,
No,
guys,
no,
wallahi,
it's
you were very
yeah.
helpful, and
You,
I'm very
you,
thankful and grateful for you.
thank you too. You were also excellent. Okay, thanks, Dr. Rimaz.
Okay. Thank you, guys.
Thank you. See you soon, inshallah.
See you.
I think, yeah, the time is late. We can end the recording and nominate for tomorrow practice.